Let's go ahead and put up the pre-test slides for our first speaker of the afternoon. Question number 1, which of the following is a characteristic of class 3 agents? Choice A, slow impulse conduction velocity and exhibit reverse use-dependent effect. Choice B, prolong refractoriness and exhibit use-dependent effect. Choice C, slow impulse conduction velocity and exhibit use-dependent effect. Choice D, prolong refractoriness and exhibit reverse use-dependent effect. Give you a moment to key in your answers. Okay, the most popular answer being choice D, with good amount of answers for the other 3 as well. Our second question: what is the most appropriate antiarrhythmic drug for a 57-year-old female with cirrhosis and paroxysmal atrial fibrillation, but no structural heart disease and normal renal function? Flecainide, propafenone, amiodarone, quinidine, or sotalol? Go ahead and vote. Okay, so the most commonly reached for one here is sotalol, but more than a third of the audience wants to choose flecainide. All right, good to know. Let's come back to that. And question number 3, which of the following is effective for treating PMVT occurring in the setting of early after depolarizations, or EADs? Choice A, digoxin. Choice B, temporary cardiac pacing. Choice C, calcium channel or beta blockade. Choice D, sodium bicarbonate. All right, about almost 50-50 split between temporary pacing and calcium channel or beta blockade. I will say, when I was studying for boards and when I'm going through my LKA and different things, I tend to turn to this lecture quite a bit. It's something that I need some brushing up on from time to time. So I'm glad to have Dr. Ciantis here to lead us through this. He is an associate professor of medicine and the director of cardiac radioablation. He is someone that does a lot of complex ablations, and so when I'm working in hypertrophic cardiomyopathy clinic, we share a lot of patients. He is the co-director of our sarcoid clinic and is one of our staff electrophysiologists here in Mayo Clinic Rochester. Kostas, take it away.
Thank you. Thanks, everyone. Great to be with you again. Thanks, Jeff, for the nice introduction. I think you heard a lot about ablation today, and that's mostly what we do, what I do in my practice. Having said that, antiarrhythmic medications will be here. We use them for a long time. They're a friend when ablation doesn't work, when it fails, when the patient is not candidate for ablation. So we'll go over the mechanisms. We'll discuss some interactions and also proarrhythmia. No disclosures related to this talk. So we'll classify antiarrhythmics according to the mechanism of action. We'll then wrap it up by implementing what we discussed to finally choose the right agent for the right patient based on the knowledge about mechanism of action, toxicities, and interactions, which is ultimately what we're called to do on a day-to-day basis. So what we have here, what we've done is actually put together a simplified animation of the action potential in the cardiomyocyte. And this is a little more specific to the ventricular myocyte. There are some differences when you look at conduction system or atrial myocytes, but this is a simplified version of how that ion balance work to create what you see on the ECG, the QRS complex, for example. And I will point your attention to the top right panel here. That is the membrane potential, essentially what the voltage looks like on the cell surface. So we have phase 4, which is the resting phase, and followed by phase 0, which is going to be the rapid entry of the sodium channel into the cell. This is what depolarization represents. This is what creates the Curious complex on the ECG. Then you have phase 1, which is going to be that early exit of potassium, the positive charge, out of the cell into the intercellular space. That is the ITO, the transient outward channel that Dr. Ackerman spoke about earlier. Remember, quinidine and Brugada syndrome. You then have phase 2 and 3, that's the plateau phase, and then the repolarization phase. This is essentially an interplay between calcium and potassium. So calcium, the positive charge of calcium comes into the cell, the positive charge of potassium exits the cell, essentially initially having a bit of a balance. That's why you have the plateau phase, but ultimately the outward potassium current predominates and brings the cell back into the negative, the resting phase 4. So knowing this, we can now classify antiarrhythmic drugs into 4 classes, and this is the most widely accepted classification, the von Willems classification of antiarrhythmic medications, with class 1 and class 3 being the membrane-active agents, class 1 being the sodium channel blockers, and class 3 being the potassium channel blockers. We'll start with class 1 because it does have 3 subclassifications that you need to be aware of, class 1A, 1B, and 1C. Obviously, these are sodium channel blockers. We'll work on that early entry of sodium into the cell. That's the major channel that regulates depolarization. That's phase 0. That's where those medications will work, and we'll see in the subsequent slides exactly how that happens. But what is important to remember is that 1As, even though we classify them under sodium channel blockers, in fact, they have quite a bit of potassium channel blocking effect as well. Remember, quinidine came up in the Brugada syndrome. It's actually an ITO blocker. It has potassium channel blocking effect. Procainamide, the same. Disopyramide, a little less so, but still some. This will be important when you think about what procainamide or quinidine does to your ECG. Lidocaine and the oral formulation mexilitine is a 1B, and then 1C, the more pure sodium channel blockers, flecainide and propafenone. Class 3, the main medications that we have there that are currently in clinical practice in the US, tofetilide, sotalol, amiodarone, also dronedarone, which is the equivalent, an analogous of amiodarone without the iodine problems. These are going to work on phase 3 of the action potential. That's the repolarization phase of the action potential. Essentially, will slow that exit of the positively charged potassium out of the cell to allow the cell to remain a little more positive a little longer. By convention, we also have class 2 and class 4, beta blockers, calcium channel blockers. We don't consider those membrane-active agents, but they fall within the von Willems classification because we use them a lot in patients with arrhythmias. So let's take a closer look at class 1 agents. These are sodium channel blockers. Remember, phase 0 of the action potential, that very beginning of the action potential. What they will do, they will slow that inward flow of sodium with a positive charge into the cell. That will essentially tilt that phase 0 rightward. It will make it slower. How that translates in your ECG is a widening of the Curious complex. Doesn't do anything if you have a pure sodium channel blocker, doesn't do a lot to the rest of the action potential. The repolarization phase will be the same, phase 2 and phase 3. You won't see a QT prolongation. So things, how that action reflects on the ECG will vary a little bit depending on the exact medication that you're dealing with. Starting with the pure sodium channel blockers, the 1Cs, flecainide and propafenone, prominent effect on the phase 0, the first part of that action potential, the depolarization, tilting as mentioned, that early phase, rightward will make the Curious complex longer. Then class 1B, the lidocaine, mexilitine, again, more sodium channel blockers, but they don't have a ton of an effect on the phase 0, even though they are sodium channel blockers. You won't see a lot of that prolongation of the Curious complex unless you're dealing with a supratherapeutic, a toxic type of scenario. But what they will do is a shortening of the QT interval, and that could be a therapeutic option, a therapeutic target in certain long QT syndromes, for mexilitine, for example. And then 1A, which again I want to emphasize, and you have to remember that those medications, 1A, especially procainamide and quinidine, and certainly amiodarone can fall under this classification as well. 1As have sodium channel blocking, but also potassium channel blocking effect. So you will see widening of the QRS complex, even in therapeutic and not supratherapeutic doses, but you will also expect to see a widening of the total QT interval. Let's look at class 3 agents now. So this is a blocker of the potassium channel. They won't have an effect on phase 0. Not much on phase 1 unless you're dealing with an ITO blocker, which would not be under class 3. Less so in the phase 2 of the plateau, but more so the repolarization phase in phase 3. That is the IKR, the main workhorse for moving the potassium out of the cell and repolarize the cell. So by slowing down that move, the outward current, that phase 3 of the action potential will stay longer, a little longer. This is how that's reflected on the ECG is a widening and prolongation of the QT interval. So knowing this mechanisms and the cellular electrophysiology, now we can think about proarrhythmia, which we defined as new or more frequent arrhythmia precipitated by an antiarrhythmic drug. 3 main mechanisms. One is slowing of conduction, which promotes reentry, and that is characteristic of class 1C agents, sodium channel blockers, slow conduction, sodium channel blockers. Number 2, prolongation of repolarization, an effect of class 3 agents by prolonging the QT essentially, and this is what this means. In addition, in combination with triggered after depolarizations, or EADs that we'll talk about in the next few slides, essentially early short-coupled PVCs that can induce a malignant arrhythmia. And finally, calcium overload, more of a secondary or third, I would say, mechanism of proarrhythmia related to calcium. It's not the most common mechanism, but is specific to a medication, digoxin, that you heard a little bit about by Dr. Ackerman. This is related to triggered delayed after depolarizations, delayed as opposed to early, which we saw in the second mechanism of proarrhythmia. So how does reentry happen? In order to understand some of the slow conduction-related mechanisms, but also the way that class 3 antiarrhythmics work, you have to understand reentry. So you have to have a fixed structure around which a circuit can propagate itself. Around the scar, for example, that's the most common structure, or it can be a valve, it can be another mechanical structure in the heart. You have a propagating wavefront that is depolarized or depolarizing tissue that has the activating wavefront and the head and the tail. And then the green portion is the excitable gap. That is tissue that is repolarized and it's ready to be depolarized by the wavefront that's coming behind it. The whole green space, we call that excitable gap. That is the gap that if you put an impulse into it, it can be depolarized and initiate a circuit. This is what it looks like. This is a normal, stable reentry around the scar, propagating wavefront and excitable gap. The head continuously tries to activate and depolarizes that excitable gap, and the tail follows. Now, when you have a class 3 agent at play, that is a dofetilide, a sotalol, or even amiodarone, what now this will do is will prolong repolarization, so the red portion of the circuit will get longer, the tail gets longer. Nothing happens to the wavefront velocity, so the speed by which the circle goes on and on is the same, but now the tail, as you will see here, extends more into that excitable gap. If you think about this effect going on and prolonging progressively, eventually that excitable gap will be extinguished. So you have now the head meeting the tail. This is how class 3 agents work in eliminating reentry. How about class 1 agents? And this now can be an antiarrhythmic effect, but it can also be a proarrhythmic effect for these agents. They will slow conduction. Sodium channel blockers will slow conduction because of that tilting of the phase 0 rightward. So the head of this propagating wavefront will now move slower. The tail has more time to catch on, and that excitable gap will get wider, longer. That now makes it an opportunity for arrhythmias to come in and cause more reentry. But it can also, if you think about this can be a way that if you completely bring the head and the tail together because it's so slow, that arrhythmia can be eliminated. So this is a proarrhythmic, but also an antiarrhythmic potential of class 1 agents. It just has to be the right balance of how much slowing do you need to create a new circuit and how much slowing do you need to eliminate an arrhythmia that's happening. We know that class 1 agents can cause proarrhythmia. This is from the CAST trial, 1989. Patients with recent myocardial infarction were randomized to placebo or a class 1 agent, at the time enconide or flecainide. And what they found was that patients on the class 1C agent had a lot more mortality, mostly because of arrhythmias. That has created essentially a contraindication for class 1C agents, and especially in patients with MI, ischemia, more generalizable now to structural heart disease, even though the concept is changing a little bit. And there's certainly structural conditions where we will use flecainide specifically. So the second mechanism of proarrhythmia that I mentioned, prolonged repolarization and early after depolarizations. This is an example tracing of a characteristic arrhythmia related to this mechanism. This is patient in sinus rhythm, but with a PVC that we would call a short-coupled PVC. This is a PVC that's happening quickly after the QRS complex, and even more importantly, very shortly or within the T wave. It's almost at the downslope of the T wave over here. It's followed by a compensatory pause, another sinus beat, another short couple PVC, another pause, another sinus beat, and now the PVC will trigger a malignant polymorphic arrhythmia. This is a mechanism that requires you to have a long QT, requires you to have an extra beat, an extra early after depolarization, and it is a mechanism that is worsened and precipitated by bradycardia, because bradycardia will make the QT interval even longer. Third mechanism is delayed after depolarizations related to high intracellular calcium. Classic manifestation and pathophysiologic substrate for CPVT and digoxin toxicity, more relevant to this talk. This is not pause dependent, that's not related to bradyarrhythmias or pauses. It's actually the opposite. It can be triggered by isopaterno, it can be triggered by pacing, exercise, and stress. So you need tachycardia to load up the cells with calcium and manifest this phenotypic expression. Bidirectional VT is a classic manifestation for CPVT, for digoxin toxicity. Very uncommon, but if you see it, it's characteristic of this extra load of calcium in the cell and delayed after depolarizations. This is a manifestation on the action potential. That is a depolarization, a brief depolarization that's happening late after the cell is back into phase 0. So this is as opposed to early after depolarization, which will happen somewhere here. Delayed or late depolarization is happening after the cell has been repolarized fully. This is just a schematic of digoxin toxicity and CPVT, just to emphasize the point of increased intracellular calcium. Digoxin will block the sodium-potassium exchanger, will result in increased intracellular calcium. It is this condition that it can be potentiated by hypokalemia. So low potassium will make this even worse. You have to treat the potassium aggressively when you're dealing with suspected or confirmed digoxin toxicity. CPVT, similar concept. This is now the sarcoplasmic reticulum that stores a lot of calcium. The ryanodine receptor is abnormal, leaky, and the calcium tends to accumulate within the intracellular space and cause that DAD type of phenomenon. This is a mechanism, a phenomenon that is attenuated by flecainide. So sodium channel blocker can be a therapeutic option for patients with CPVT. There's more than this to digoxin. There can be a broad spectrum of clinical toxicities with supratherapeutic digoxin, including high-grade AV block. The digoxin actually causes a hypervagotonia, increased vagal effect, and at the same time it causes automaticity because of the calcium overload and DADs. So you can have a very classic combination of high-grade AV block because of the vagal effect and junctional rhythm, junctional ectopy because of the automaticity. Very uncommon, but if you see it, it's probably digoxin. You might have focal AT, atrial tachycardia, and you might see bidirectional VT as mentioned also with CPVT. So let's do some interim questions here to review some of these mechanisms of proarrhythmia. This is an ECG and I will just show you this in the patient who has been treated, maybe been loaded with a medication in the hospital. So what is the mechanism of proarrhythmia here? Three options. The mechanisms that were reviewed with slowing of conduction or reentry, prolongation or repolarization with EADs, or calcium overload. Do we have Vivox here? Okay, perfect. Let's take a moment to choose between one of those three. And I will go through that tracing as soon as we have a number of answers. Okay, excellent. So most of you chose prolongation or repolarization with EAD, and let's review this. This is, again, sinus rhythm. It's a little similar to the tracing I showed you a few slides ago. Sinus rhythm with a very, very long QT interval. This is more than 600 milliseconds. The T wave is almost in here, barely can see it, because there's a PVC happening right at the downslope of the T wave. This is PVC, this is sinus beat with a very long QT. Sinus beat again, very long QT, and the PVC. And now this is what really causes the arrhythmia that you see here, the fact that you have a long pause. So there's a patient who has some sinus node dysfunction, or maybe is resting nicely in their bed, but this is a sinus pause that then makes this QT even more pathologic. And as soon as another PVC comes in, it will cause thankfully in this case, a non-sustained run of polymorphic VT. So this is a classic example of, say, someone, in the right scenario, is someone who's in the hospital for dofetilide loading, that might have a little sinus node dysfunction, and this is why people in the hospital when they're loaded with dofetilide. Next question, again, mechanism of proarrhythmia here, and this is the tracing. Same options. We can open the poll on slowed conduction, reentry, prolongation, repolarization with EAD, or calcium overload with DAD, and we can vote on these on this question. This is almost a pattern that you should be able to quickly recognize. It's just know it, that if you see this, it's one of two things, and you should be able to eliminate everything else. We can see the responses. Excellent. So almost all people voted for calcium overload with DAD, and this is exactly what this is. This is, in fact, more specifically bidirectional VT. This could be the stress test of a patient that has CPVT. When they get to about 120, 130 beats per minute, you might start seeing this bidirectional behavior with complex ectopy. Could also be a patient with digoxin toxicity in the hospital. This is calcium overload in the cell for the mechanisms that we reviewed earlier. And then the final tracing here, again, with the same questions, we can open up the voting on slowing of conduction, reentry, prolonged repolarization, or calcium overload, same options. I guess we chose the other two already, so only one left. Yes, almost there, 96%. So this is, let's get a round of applause. Excellent. Who voted for the other two? Let's see. Just kidding. So slowing of conduction and reentry. So this is a patient who has atrial flutter. Could have been atrial fibrillation, but we put him on the sodium channel blocker and organize that atrial fibrillation into flutter. Now, this flutter will conduct to the ventricle one-to-one. Remember, that's why when we treat with flecainide, we want to have patients on some AV nodal blocking agent as well. And now the ventricle is seeing a really fast heart rate. But because they have the sodium channel blocking effect, the conduction within the myocardium will be slower. It's a bit of a paradox. You have a rapid rate, but the conduction, in fact, in the myocardium, what the actual myocyte sees, what it senses, it's actually a slow conduction. What this will translate to in the ECG is a white complex. This is a white complex QRS with a sawtooth type of appearance, which gives you the clue it's flutter underlying with a white complex conduction to the ventricle. Differential for this would be ventricular tachycardia, but in this example, this would not quite fit the stem, unless I told you this patient had VT previously, and maybe this organized into this type of arrhythmia. But this is a classic example of flecainide overdose or toxicity in someone who has taken the medication for an atrial arrhythmia. So moving on to use and reverse use dependence, a very important concept that also explains a little bit this last question. So this is related to the modulated receptor hypothesis. The use-dependent channel block means that a medication will bind to the open or inactivated state. So by that, what you get is that the medication that you're dealing with will have the greatest effect, the greatest antiarrhythmic effect at the faster heart rate, because the channel has to be open or at least inactivated if it's not participating at that phase of the action potential. The opposite is true for reverse use dependent channel block. So you have the greatest effect when the rested state predominates for that channel, and that is translates into greater drug effect at a slower heart rate. Use dependence, so faster heart rate, faster, more effect, antiarrhythmic effect is classic for class 1C agents, flecainide and propafenone. And that's why these medications are most effective for terminating arrhythmias. That's why we give them as pill in pocket. You have a fib, you take a dose of flecainide, converts, and that's the reason for why that works well is because the atrium is in a very rapid arrhythmia, and we almost take advantage of the use dependence feature of class 1C agents to cause a conversion. We want to monitor pharmacologic effect, which is the QRS widening in the case of flecainide or propafenone with a stress test. We want to see the heart rate go up a little bit so we can make sure that the QRS complex doesn't get very long. And these arrhythmias, it's similar to the ECG that I showed you earlier in the last question, that do have the potential for widening the QRS complex during SVT. You get SVT with 1-to-1 or 2-to-1 conduction in the ventricle. You might see the QRS complex getting wide if you're treating this patient with flecainide or propafenone. Classic example again with atrial flutter. This patient already has some incomplete right bundle branch block at baseline. We put him on a treadmill, exercise, and the heart rate goes up, and now they're conducting that arrhythmia to 1-to-1 in the ventricle. But as you will appreciate here, the QRS complex is wide, and it could be delay within the bundle. So the right bundle that was previously incomplete is now complete, and you see a complete right bundle branch block aberrancy. Or this could be intramyocardial delay with the right bundle pattern, where you now see the conduction within the ventricle getting a lot slower. That's why most of the time we'll bring patients back for an ECG and plus minus a stress test within about a week or 10 days after starting new initiations of flecainide or propafenone, and we want to stop the medication if your QRS gets more than 15 to 20% above and beyond the baseline. It's normal and it's actually desirable to see a little bit of a change in the QRS complex. You don't want to see more than about 20%. So class 3 agents do the exact opposite. So they have the greatest effect when the heart rate is slow, when patients are resting at nighttime, when they're sleeping. Then that's why we don't use these medications for conversion. We don't do pill-in-pocket sotal or dofetilide. They don't work as well when the patient is already in arrhythmias, and that's why when you load the patient in the hospital with dofetilide, only about 5 to 10% will convert with the dofetilide alone. Usually you have to do a cardioversion and then let the dofetilide keep them in normal rhythm. You want to assess the pharmacologic effect, which is the QT prolongation at rest, and these medications do have the potential for pause-dependent polymorphic VT related to slowing of the heart rate, which could be conversion pause, so you're in AFib and you convert and you might have a few seconds of a pause before the sinus rhythm, is back, or during sleep when you might have pauses or relative bradycardia. So that is why patients need to be in the hospital when loading with dofetilide or sotalol. An example here of a patient in sinus rhythm, long QT at baseline, so this patient does have a baseline predisposition here. Now with rate slowing, and what's happening here is 2-to-1 AV block. This could be physiologic AV block in someone who's asleep on a telemetry bed. But what effectively happens, the rate of the ventricle is half of what it was when they were awake. And now you have this potential for a PVC and early after depolarization EAD in the T wave to initiate the polymorphic VT. This is a manifestation of the pathologic reverse use dependence in someone who's treated with a class 3 agent. So we avoid class 3 agents in someone who has excessive bradycardia, sinus node dysfunction, long pauses, propensity to 2-to-1 AV block. If you really need to use a class 3 agent in someone with sinus node dysfunction, you might need to put a pacemaker in to keep that heart rate up and prevent those significant bradycardia episodes. Amiodarone requires a special mention because it is rate independent, does not have reverse user use dependence. It affects IKS and IKR, which are both potassium channels, equally, and that's why that balances out that rate dependence. It does have a consistent effect across a range of heart rates, and proarrhythmia is rare despite the action in all of the potential channels, sodium channel beta, it's a beta blocker, it's a potassium channel blocker. Probably because of that multitude of effects, it is not a proarrhythmic medication unless a lot of other things have to be going wrong. So we covered learning objective 1, we reviewed mechanisms, we reviewed antiarrhythmic action, proarrhythmic action, rate dependence in mostly with class 1 medications and class 3 medications. Remember with class 1, sodium channel blockade, class 3, potassium channel blockade, the difference in mechanisms in antiarrhythmic action between class 1 agents, which will slow the conduction, as opposed to class 3 agents, which will prolong repolarization. And finally, the issues with proarrhythmia and dependence. So a couple of words about metabolism and the routes of elimination of these medications. As with any other medication, most antiarrhythmic drugs will be cleared via the liver. So you have amiodarone here in the first column, amiodarone, lidocaine, mexiletine, propafenone, also the calcium channel blockers and also the beta blockers. What you need to remember, though, is that some of the key medications that we most often use in clinical EP or cardiology do go through the kidney. Sotalol is a purely renally metabolized medication, renally excreted medication. Dofetilide, almost purely renally excreted, 80 to 90%. A small percentage of dofetilide will go through the liver. Digoxin is also renally excreted. Now, where things get missed sometimes is the fact that some of these medications have almost a semi-balanced distribution and metabolism through the liver and the kidney. Flecainide, for example, is mostly hepatic but does have a pretty significant renal metabolism. So if you have someone in end-stage renal disease, you have to be a little cautious with flecainide or advanced CKD. Procainamide is a very interesting drug. It does get metabolized in the liver to, it's another active metabolite. So the primary drug is an active drug, but it's metabolized to NAPA and acetyl procainamide in the liver. NAPA itself is renally cleared. So you might have someone who has renal dysfunction that will get procainamide toxicity, not because of the procainamide itself, but more so because of NAPA. And that's a 50-50 distribution for kidneys and liver. Quinidine is also about a 50 to 60, 70% for hepatic distribution and metabolism, but also goes through the kidney. So this is an important mix of metabolism, metabolic pathways to remember for flecainide, procainamide, and quinidine. Here's a scenario that you might come across. It's a patient who is on propafenone and may develop or demonstrate reduced metabolism via the liver. What that will look like is bradycardia, significant bradycardia, and widening of the QRS complex. This is because propafenone has a beta-blocking effect. It's structurally similar to propranolol, so it does have a little beta-blocking effect. Sometimes we use that for a therapeutic advantage. But when it accumulates, that can cause significant bradycardia. And then you will see also broadening of the QRS complex because of that sodium channel effect. 7% of the population are slow metabolizers of propafenone and a few other medications that we'll see in the next slide. So the CYP2D6 that metabolizes propafenone via the liver, that can be a slow metabolizer for about 7% of the population, especially Caucasians and African Americans. So the important CYP450s, the important enzymatic pathways for antiarrhythmic drugs are the 2D6 and 3A4. Those are listed here. I think it's important to have a kind of a broad idea of what medications go through each of these pathways. As mentioned, about 7% of Caucasians, African Americans are poor metabolizers through the 2D6. Only 1% of Asians have the same issue. So this is something to think about if you have someone who's demonstrating a sodium channel toxicity or an excessive effect despite just using a relatively normal dose of a sodium channel blocker. Interactions, numerous, especially when you have amiodarone on board and a few other medications that we'll review in the next few slides. Antibiotics are inhibitors for 3A4. So if you have someone on the macrolide antibiotic and dofetilide, that can cause some problems. You have to watch the QT a little closer. Grapefruit juice, some dietary things that you have to counsel patients on. Amiodarone requires a special mention because it does have a lot of interactions. It will increase the INR. So if you're on warfarin and amiodarone, you definitely have to counsel the patient in the anticoagulation clinic that they have to adjust their warfarin, usually downwards. It will increase digoxin effect. It will increase the levels of digoxin and its effect. It will increase colchicine, which is relevant for us electrophysiologists. Sometimes we'll use colchicine around the time of an ablation plus amiodarone. It will increase levels of colchicine, so you have to reduce it, but also will increase the levels of cyclosporin and tacrolimus. So patients on immunosuppression, you have to make some adjustments. QT prolongation, a very important interaction and potential for toxicity when you co-administer antiarrhythmics with other medications. Antibiotics, levofloxacin and azithromycin more classically, that can prolong the QT. Some of the antidepressants, anxiolytics, that can have a QT prolonging effect. And then the immunosuppressive medications I mentioned. So a quick word about SSRIs, because they come up in practice all the time. You'll get an inbox message saying, hey, my patient is... You have them on Sotalol or Dofetilide. They need to be started on something for their depression, anxiety. And in that case, realistically, you probably don't want to just stop the antiarrhythmic medication. You also cannot tell them don't start anything. You have to do something. You can still use them with caution, and that's obviously something to offer in terms of a surveillance program and counsel the referring provider or the psychiatrist in this case. But you can use fluoxetine and paroxetine. These are the two medications that have the least potential for interaction, the least QT prolonging effect when you use them with or without a class 3 antiarrhythmic or a class 1A antiarrhythmic. Monitoring of this medication is very critical. You can't just start them and forget about them. You have to bring the patients back. I've listed here baseline assessments for all of these patients. With an asterisk here, we have CYP2D6 genotype. If there is a family history of some sort of pharmacogenomic problems, and you're going to start a patient of flecainide at a high dose, consider doing the genotype if that's something that you're going to use for a long time for that particular patient. And you'll bring the patient back in about a week or 10 days to do an ECG for sure, and plus minus a stress test, and we can review some of the plus and minuses when you do a stress test in those patients. With Dofetilide and Sotalol, they have to be in the hospital. With Sotalol, the practice has changed a little bit, especially around the time of COVID and post-COVID. We've been a little more flexible about doing some of these loads in the outpatient setting, but FDA guidance has traditionally been that they have to be in the hospital on telemetry for 5 to 6 doses, and you'll bring these patients back in 3 to 6 months to repeat an ECG and a renal function. Now, the threshold to stop or reduce Sotalol Dofetilide is about 500 milliseconds. So anything more than that gets a little tricky, especially if someone does not have an ICD. Amiodarone, it's its own special science of monitoring and protocolizing this. I think is important if you have a busy practice with a lot of amiodarone patients. Obviously, the issues with the endocrine, thyroid, hepatic toxicities, lung toxicities, and as well as the ophthalmologic. So we do in everyone a thyroid function, liver function, baseline PFTs and the chest X-ray, and then we'll do a baseline eye exam. And then every 3 to 6 months, we'll bring patients back for blood tests and the annual pulmonary examination with PFTs and chest X-ray and annual eye exam. One note about the eye exam, it's a bit of a misconception that sometimes gets translated to the patients, not having a clear understanding why they need to see an optometrist every year or the ophthalmologist. We do it mostly to look for optic neuropathy. We don't do it as much for the corneal deposits, which are very common. So more than 90% of people on amiodarone will have some deposits after a few weeks of treatment. Most often those are asymptomatic, thankfully. Some patients may have blue halos, so that can cause some vision disturbances, some blurry vision. In those cases, you have to consider stopping the medication, but most of the time, the optometrist will see them, will say, we know about it, it's good to know that they're there, but we wouldn't stop the amiodarone unless there were actual symptoms. But optic neuropathy is a serious problem, can cause vision loss. Thankfully, it's uncommon, less than 1%, probably more in the 0.5% range. But if it is there, you obviously have to stop amiodarone right away. So finally, selecting the best drug, and this will apply all of what we discussed with mechanism of action, toxicity, interactions, metabolism to find the right drug for the right patient. Some of this has been reviewed already in the previous talks on AFib and VT earlier today. But if you have a patient without structural disease, the range of options is pretty wide. You have flecainide and propafenone as first-line options. Sotalol can also be in the first-line group. Second-line, dofetilide. Amiodarone, I'd say, is an option, but you wouldn't really use it in someone without structural disease. Most of these patients will get an ablation. If you have coronary disease, the main distinction here is you don't want to use class 1C antiarrhythmics. You go to the class 3s, dofetilide and sotalol, and secondarily as well amiodarone. Heart failure, we would not use sotalol in heart failure, especially if it's decompensated. Amiodarone and dofetilide are probably your best friends. Again, you don't want to use 1C antiarrhythmics in the setting of heart failure. Typical patient for 1Cs, flecainide or propafenone, usually young patients on paroxysmal AF of recent onset, highly symptomatic, without structural heart disease. You make the argument here in the question, which I think is appropriate, why not offer an ablation? And yes, the answer is ablation would probably be a first line for such a patient unless there's some circumstance that either the patient does not want an ablation or something else. But this is the type of patient that flecainide would be a very reasonable starting point. Class 3 agents, more so for persistent AFib, so thinking about a more advanced phenotype of AF, persistent AF, structural disease without significant renal dysfunction. Remember, those are renally excreted and metabolized. So if you have severe CKD with creatinine clearances less than 40, especially for sotalol, then you have to be quite cautious about with those agents. But adherence is key. Those patients have to be very meticulous about the scheduled regimen. They cannot be missing doses. They cannot be shifting the doses around. Maybe I'll take it 2 hours later or 3 hours later. You have to maintain the therapeutic levels within a pretty strict range, especially for dofetilide. Amiodarone is a last resort for atrial fibrillation, but we have to use it sometimes, especially if it's a bridge to a more permanent intervention, maybe an ablation or something else, or if it is a temporary condition like a post-op AFib type of scenario. But mostly would use it in older populations with persistent AFib, a significant structural problem, poor renal function when class 3s are not an option, patients who have failed other medications or failed an ablation, and if they're not a good ablation candidate. For VT, again, the distinction goes back to structural disease or no structural disease. If it's monomorphic VT with scar, for whatever reason that scar might be, amiodarone and sotalol will be your best bets here. Plus minus maxillatine, you want to avoid class 1Cs. The more special scenarios of polymorphic VT and VF in the setting of ischemia and inflammation, lidocaine, IV lidocaine is to be used in the ICU or in the hospital. And then the more specific scenarios that you guys reviewed earlier with Dr. Ackerman, some beta blockers and flecainide, and as well as quinidine for genetic heart rhythm syndromes. So this is a sample of a flashcard. We put together almost all of the antiarrhythmics, I think, that could be relevant to your practice. We have mechanism of action, indications, contraindications, proarrhythmic mechanisms. So sort of a quick reference. If you have a specific question about a drug, you can reference this, and it should be available in your syllabus. So we'll close with the key points. Conduction slowing early and late after depolarizations are the main mechanisms of proarrhythmia. Class 1C is most effective at faster heart rates, the use dependence phenomenon, as opposed to class 3s that are reverse use dependence. Monitoring and the safety monitoring and the proarrhythmic and other toxicities with medications is very important, especially class 3 and amiodarone. And finally, the arrhythmia profile and the patient profile will dictate drug selection. Important distinction between class 1C, the earlier AFib phenotype and the healthier patients, versus class 3 and amiodarone in the more severe cases. Thank you very much for your attention.
All right, come on over, Kostas. We're going to start by going through your post-test questions here.
Great.
So which of the following is a characteristic of class 3 agents? A, slow impulse conduction velocity and exhibit reverse use dependent. Choice B, prolonged refractoriness, exhibit use dependent. C, slow impulse conduction velocity and exhibit use dependent. D, prolonged refractoriness and exhibit reverse use dependence.
Great.
All right, 83% chose choice D, which is a pretty good lift, actually. but we still have some hanging on to the other options. Let's say that this one didn't come easy for you. How would you study this to get better or more facile at this? Because it follows a trend. It follows kind of these things that you've said. But what would you use to study and drive this home?
Well, two ways you could approach this. One is to think about the mechanism and where class 3 agents work. Remember, class 3 being the potassium channel blockers that work on phase 3 of the action potential. That's easy. Class 3, phase 3, potassium channel blocking. Phase 3 is the repolarization phase. So you know that if you impact that potassium outflow from the cell, the result will be prolongation of the repolarization. That's a QT interval. So you know you have nothing to do with impulse conduction. That's a sodium channel problem or effect. If you're dealing with refractoriness and repolarization, that is a class 3, phase 3 effect related to potassium. So you've taken out the slow impulse or the fast impulse effect of which is more of a sodium channel blocking effect. Now the reverse use and use dependence effect is the way I think about it, and I think it's helpful to memorize it, is use a medication that you've used in your practice as an example. Think about the patient on dofetilide or sotalol, where you've seen that QT interval get longer if you're bradycardic. So that is a reverse use dependent effect where you have most of the potassium channel blocking effect in that patient who's bradycardic, has pauses, and I'm sure many of you have stopped or reduced the dofetilide or the sotalol when you get that loaded in the hospital because they were slow overnight and you didn't feel very comfortable continuing on a high dose. So class 3 agents, potassium channel blocking effect, phase 3 of the action potential, repolarization phase of the action potential. They have nothing to do with impulse conduction. That is a sodium channel effect in phase 0. They will have an effect on refractoriness. They will prolong refractoriness, so B or D will be your options. And then between use and reverse use dependence, just have to remember that the dofetilide class 3 agent will have that nighttime effect. Nighttime torsades, it's a dofetilide problem. Maybe remember it this way, nighttime patient in the hospital, about dose 4 of dofetilide, and you see a very long QT and runs of non-sustained polymorphic VT. That is your clue to stop the dofetilide or reduce it.
All right. Beautiful. Question 2. We've got this gal with cirrhosis, 57-year-old female. We're putting her on an antiarrhythmic for her paroxysmal atrial fibrillation. No structural heart disease, normal renal function. What should we use? Choice A, flecainide, B, propafenone, C, amiodarone, D, quinidine, E, sotalol.
Great. Maybe we can see the pre. Nice.
Wow, that's amongst our biggest lifts. That's great.
Yeah, this was a bit of a distractor. Flecainide is a seemingly very good option for this patient. It's paroxysmal AFib. Whenever you have paroxysmal AFib, flecainide, propafenone are great options. The kicker here is the cirrhosis. And because of the cirrhotic liver, poor synthetic function, poor metabolic function, flecainide would not be a great option. Remember, flecainide, it was one of the top of those 3 agents that are in the mixed category. So it will have some hepatic elimination, quite a bit of hepatic elimination, and you don't want to use that in a cirrhotic patient. Sotalol is the only option that makes sense in this patient, even though they're paroxysmal and they have no structural disease. So you wouldn't be your go-to unless if it wasn't for the cirrhosis. But if because of the cirrhosis in this case, sotalol is a good option, and they have normal renal function, so that helps you a little bit. Clue you into the fact that a class 3 antiarrhythmic with sotalol or dofetilide would be good options for this patient.
Great.
Propafenone is through the liver. Amiodarone has a lot of liver involvement. Quinidine, same thing. More in the mixed, but a lot of liver pathway.
All right. Tricky question, but our audience did really well.
Really good response, yeah.
All right. Which of the following is effective for treating PMVT occurring in the setting of EADs? DIG, temporary cardiac pacing, calcium channel or beta blockade, or sodium bicarbonate?
Okay.
All right.
Yeah, so this is a bit of more of a challenging one, I think, and I'm glad we have a bit of a spread here, but definitely move towards we had a change towards temporary cardiac pacing, which is good. Now, the key concept here is that patients, if you have early after depolarizations, EADs, you have to immediately think about bradycardia. So this is a bradycardia pause-dependent mechanism. So the therapeutic target here is fixed QT interval. That is what will cause PMVT with EADs. How do you fix that? You correct the potassium, the magnesium. That's not an option here, but those will be things to do. Remove the QT prolonging agent, obviously, but more importantly, and acutely, correct the bradycardia. That is how you get the long QT. That is how you get PMVT with early short coupled PVCs. So this would be the best way to do this acutely is temporary cardiac pacing, whether it's temporarily externally or with a transvenous temporary lead. Now, the calcium channel beta blockade is an interesting choice here, and I can see why a lot of people chose that. It can probably help. It can help if you have PVCs, but what it will do in the absence of pacing support, it will make your bradycardia worse. So there you don't know which way you're going to go. If you have worsening bradycardia because of the calcium channel blocker that you just prescribed, you could actually make the QT even longer and have more short couple PVCs and cause PMVT and VF. I would use beta blockers, I would use calcium channel blockers if I have a temporary pacer in place. And I would do those to suppress the PVCs. But remember, calcium channel blockers, beta blockers are more so to treat DADs, delayed after depolarizations. When bradycardia is not a concern, you can use them. But if you're bradycardic and you have EADs and long QT, you have to fix the bradycardia. Sodium bicarb is an antidote for sodium channel blocking. So if you have a flecainide overdose or propafenone overdose, that will be the way to mitigate that. Digoxin will not be a treatment for anything really related to PMVT.
All right, I've got 2 or 3 questions I want to get through here. There's obviously more than that, a lot of engagement with your lecture through the dashboard here. But say you're thinking about initiating a class 1C agent. How do you approach someone who has some baseline conduction disease? Mm-hmm. Is that, would you still use a 1C? Is there a QRS that's too wide to use a 1C? And I'm going to hold you to just 15 to 20 seconds because I want to ask you a couple questions here.
Yeah. Excellent question. So with 1Cs, baseline conduction disease is an important consideration. You have to be mindful of that because what the 1C will do is it can make that incomplete right bundle branch block even worse. So my practice is if I have anything more than 100, 110 milliseconds for an incomplete or an IVCD, I typically would not use flecainide or propafenone. If I do use them, I would start low and go slow. Bring the patient back a few weeks later, a few days later, repeat an ECG. I would definitely put such a patient on the treadmill. I want to see what the heart rate, with an elevated heart rate, what the QRS complex does. So I said plus minus stress test. This will be definitely a plus stress test if I have baseline conduction disease. I would also do a stress test as a side note, if I'm using more than 100 BID, definitely 150 BID in the normal body habitus, I will bring those patients back for a stress test.
All right. Say you're initiating an antiarrhythmic agent. What is your approach to anticoagulation? Because this might take someone in AFib out of AFib, pharmacologic cardioversion. So do you do a TEE on all those people? Do you empirically anticoagulate? Do you use Chad's VAS? What do you do for anticoagulation as you're using these agents?
Yeah, so I would think about them a little bit separately. You know, the anticoagulation decision is based on, at least on our current practice, and that will probably shift in the next few years. We anticoagulate or not anticoagulate based on Chad's VASc risk stratification. Now, if you do have a patient who has been in AFib for months and they were not anticoagulated, and I wonder if that's where the question was going at, and you're thinking about starting a medication, I wouldn't do a pharmacologic cardioversion unless I've ruled out a thrombus. So the way I would deal with that is if it's an unknown duration of AFib or if it's known and long, more than a few days, I would put them on a blood thinner, I would do a TE, and honestly, I would do a cardioversion if I'm doing a TE, and then put them on the drug. So I would treat pharmacologic cardioversion similar to electrical cardioversion when it comes to the risk of stroke. It's probably less. So electrocardioversion causes more stunning compared to pharmacologic, but I would still treat them the same if when it comes down to decisions about blood thinners.
All right, we have 30 seconds left, okay? So there's like a one-sentence answer because I'm going to use up 20 seconds gabbering here with the question. But since there are 3 questions in the list here, give me your one-sentence take. I know you're going to answer much more thoroughly in the portal as everyone else has been doing here in the dashboard. But your one-sentence take, how often do you use dronedarone?
Yeah, dronedarone is
one sentence.
Very rarely. More often, we stop it, and I'll leave it at that.
All right, and I know you're going to go more into that in the dashboard. I know there's some questions about that, but join me in thanking Dr. Tsiantis for an excellent lecture.
Thank you.